Hello, everyone. I'm happy, just proud to have with me today Dr. Chaminie Wheeler. She's going to be speaking with us about her practice model. Let me tell you a little bit about her. Dr. Wheeler graduated from Virginia Wesleyan College, magna cum laude, in mathematics and biology. She received her medical degree from Des Moines University and then did her residency at Blank Children's Hospital. She is a board certified pediatrician. She is an advocate for her patients. She exemplifies dedication to healthcare, to her fellow physicians, to the patients, to her community. And I'm so pleased to have her here today. She's the current Lehigh County Medical Society president, and we serve on the board of trustees of the Pennsylvania Medical Society together. So welcome, Dr. Wheeler.
Thank you so much. It is a privilege and an honor to be here, and it's just wonderful to be under the mentorship of leaders like yourself. So it's wonderful.
Oh, thank you. All right, well, let's get into it. Let's talk
Yeah.
about your practice. So, could you describe your current practice and what's your work? What your work is like? Um,
Absolutely. So my husband and I, we have what we call a direct primary care office. And I know a lot of people might have heard the name, but may not understand what the model is all about. It is like concierge medicine, is a membership model, but it's not concierge prices. It's really meant to be for the average everyday person. Our membership fees are only $50 a month to $95 a month. So and that's for unlimited office visits, 24/7 access to the doctor. That's the most biggest benefit of membership. Um, I would say our practice, 98% of our patients have insurance, yet they chose our practice for their health care, for their primary care, for my husband and I, because our current medical system, our patients, they have insurance, but the insurance doesn't necessarily translate into care and access. There's long waits to get in and all of those things. So all of those reasons, and our patients just really want a relationship with their primary care doctor. Those 7 minutes office visits are just not what they want. So our it's been remarkable. Our patients, they have insurance. We need them to have insurance for those big ticket items. And the whole purpose of direct primary care is to really to transform healthcare. So foundation of for our patients, primary care can have access based on a relationship so that you get to get people better. You can take that 70 minute, in medical school, I remember being taught that 70% of what I figure out what's going on with a patient is taking that detailed history. 15% is doing an exam, and the other 15% is doing the testing. And our current system, we flip that. When we get 7 minutes, we really don't have time to take a history. And so, it's unfortunate. I feel so sad when I think about it for my colleagues and that the role of a physician often has been degraded to somebody who can prescribe or somebody who can refer, instead of being able to use all the knowledge and all the countless hours that we studied to learn what it is to help our patients. So that's our model.
so, what are the obstacles to getting your model started? I mean, that sounds so much better for
Right.
patient care, and yet there isn't. It's not the primary model that is being
No, not
utilized
at
in this
all.
country.
Not at all.
What's holding us back from this model?
I think it's fear. For me, it's scary to think that why would a patient choose to pay membership, and even if they don't see me to do this, is $50 per patient? Is that really a sustainable economic model? Like, am I really going to be able to keep the lights on in my office with charging those fees? I mean, for me, it was a huge we are so focused on insurance and having that, if we don't have insurance, we don't have health care, that it's so hard to let go of that concept and to say, it's far better to do this. And it took us about a year and a half to wrap our head around when my husband and I decided to open this practice, because we continue to look at the insurance model because that's what we're used to. That's what we're taught in residency programs. We're taught that 24/7 call is crazy. Why would you possibly do that to yourself? You know, and so, I mean, honestly, financial restraint and the thought of 24/7 call was scary. And I think those were the biggest obstacles. And now I've been on 24/7 call for 2 years, and it's been wonderful. I go sometimes, a whole weekend without a phone call. And I can tell you every text, my patients, they do have access to 24/7, always starts with, "I'm so sorry to bother you." On a yeah, and the value in it is because it's a relationship. I respect them, they respect me, and it's all about teaching your patients when is it appropriate to pick up that phone and call, and when is it not. And it's not, and it's just so rewarding, because of that. All the burnout that physicians have today, it's because a lot of our care is not based, starting at the initiation is on not a relationship. And when I mean, even if like your kid does something bad, but because it's your kid and it's your relationship, it's easier to take that hit, right? And so it's the same thing with patients and doctors too. When it's based on a relationship, you can really do anything.
Now, I'm sure people, and hopefully many of our colleagues will be interested in trying to start up this kind of practice. So if you could go back in time to when you were getting this thing off the ground, what could you tell them for somebody who's interested and says, you know what, I want to do this? Is there something you could tell them that was difficult at the beginning that you could have told yourself starting out that you wish you knew then and that you can pass on now?
Absolutely. I think the biggest is to talk to another direct primary care doctor. Every one of them has a different practice, different model, different things they do. But when you go and just visit another DPC doctor's office, you'll see, and you honestly realize that all it takes to be a doctor is your brain and your stethoscope. Everything else is kind of ancillary, like you really can make a difference. And I think that was, I think, is really, it's that, being able to pull somebody up. I mean, just this year alone in our practice, our office, we've had 8 different physicians who have visited our office looking into the model. And couple of them, 2 of them will be opening up their DPC in 2026. So it's a process. You have to figure it out. And the other thing, one of the things we did, I don't necessarily suggest anybody do this. We purchased a building and renovated it, which was a very high overhead. You don't need to do that. You can rent a space. For us, it worked out the way that the things open up, but like really it's just a space to start seeing patients. And right now, our patients want this because they don't have access. Um, and the other thing I would tell anybody, how hard is it hard to start this? Think about all the urgent cares that are out there in every corner of our society today. And why did we all of a sudden have this model in medicine called urgent care? Why did it even come up? And for me, I really believe the urgent cares, what the market, the reason that it is happened is because our patients get sick and they don't have access to their doctor, their primary care doctor. They have to go someplace. Our ERs are overcrowded because primary care is often done in the ER. So as if we can just really do primary care, I mean, I honestly think as more primary care patients have access to primary care, urgent cares will start to dissipate because patients won't need that because they have access to their doctor. And so like those are the, so look around, see where it is. And if you see an urgent care anywhere close to you, you probably can open up a DPC practice and thrive because all of those patients who are using that urgent care needs care and they don't have access.
So you feel that this could really thrive in all different settings? You're in a somewhat suburban or even rural type setting. Tell me a little bit about that, and how do you think this could translate to a more urban center?
I think that's a great question. I live in Briningsville, which is west of Allentown, and our practice in Kutztown, which is honestly very in a center of a Amish Mennonite community actually. And so a lot of people think it's because it's in the Mennonite community that our patients are from that community. We do have a couple of patients, but I would say we have maybe about 4 families total from that community. Everybody else is not from that community. And the reason is the Mennonite community don't really think of membership. They are more like fee for service, right? So we do have a portion of our practice where we'll do a one-time consult, because they're sick, they want to be seen, and that's it. So we have that portion also to our practice, and we chose to do that specifically for that community, because that's, they don't buy monthly memberships to gyms, right? So it's not the same thing. So that is, and I think in an urban setting, it's all about I think the education that would be needed, because like for one of my patients actually was seen for 55-minute one-time consult by a local by not a local but a hospital in Pennsylvania. I don't want to name any names, but and they were charged $4,090, I believe, for 55-minute consult. Nose testing was done, no, nothing. So when we talk about the cost of healthcare, that's not even proportional to the delivery of what we're providing. The physician who saw them is not going to get that money, that $4,000. They did the work. They went, it's not that, but the blame from my patient, the doctor charged me for, and is what the patient came and told me. So at the moment I'm trying to work with this hospital to make this a fair 55-minute office visit and not the 4,000 plus. But it's really unfair. The doctor did a good job, the doctor saw the patient, but the patient is mad at the doctor because that's what they got charged, and it's not the doctor's fault. um and they're not, not going to see any dime of that 4,000 because they're salaried. Our employed colleagues are salaried and they don't get to see that. um so I think those types of things is what makes this model harder in an urban setting. But as the movement continues and the patient education, I think is the biggest thing. I think it is. In 2017 to 2021, there was 241% increase in DPC practices, which is dramatic. This is called RevDoc, who published this in May of 2025. There is an increase, 159% increase in clinician adoption of this model. And then the recent bill, the HR1, the big beautiful bill, that one that passed, it expanded. One of the good things it did was it expanded health savings accounts to include direct primary care membership along with things like gym memberships. So where wellness became more of a focus. So now and I know there's big companies that are now looking into for their employee health plans instead of necessarily negotiating with insurance to put money into more of their their employees' HSA accounts and let patients choose what they want to do, what type of insurance they want to purchase. Do they want to buy just a catastrophic coverage that covers the big ticket items, more like car insurance, where it covers, the heart attacks, the chemo, or things like that, the car accidents, and everything else you pay out of pocket. Our patients are choosing that. Our patients who have insurance have recognized that they can get better care by directly paying for our services. Our patients actually pay directly for, they have insurance and they often don't use their insurance for lab work
Mm,
even though they can. And the reason is we give them our pricing for labs. And then I tell them, these are the codes, check with your insurance and see which is better for you. Do what's better for your pocketbook. And I just had a patient I did lab work on. It was a fertility workup and by her fertility specialist. And the lab work was going to cost $3,000. She emailed us and says, "Hey, this is the labs I need drawn. How much would it cost at And so I looked up with our, we have an account with Quest and H&L, and I gave him the prices. I said, this is, and it was like $340. So
mm.
like it's unbelievable, so it's gonna work. It's beautiful. It truly transforms the delivery of healthcare in every perspective. Um, Membership allows the business of medicine, our office, to run because I don't have to think about the number of patients I need to see every day to make sure that I can keep my lights on. The membership just runs, is a predictable income. It runs the office. And then when we make appointments, I don't have to say, I can see my patients as often or as little as I want, or that's needed for that patient's care. One of my favorite stories is I have a 13-year-old patient who weighed 314 pounds. And his coach is the one who got him into our office. And we worked in things, and he has lost 62 pounds just being in our office. And the amount of healthcare dollars that saves by doing that is unbelievable. I saw him every week, and I didn't do anything big. I was more his cheerleader, from week to week. But that touch point, that care, it didn't take a ton of my time. He looked forward to coming, getting his way in, getting checked, and then tell him, go do this week. It was very rewarding for me personally and for him. And if we can get this, one patient not to develop hypertension, diabetes, and all of the sequela that comes with all of that kind of stuff, you can't put a price on the healthcare dollars that's saved.
So how do we get the word out about direct care? One thing that we talk about medical education, and it doesn't always cover all of the options that a physician might have,
Right.
or that a medical student, a new arrival into our health system might have. So how do we make sure that our new docs know about all the options they have? I mean, I think all they really hear about is the normal trend, which is
Right,
basically you become an employee at a big health system.
right,
How do we
100%.
let them know there are other options there?
So, thank you for asking that, because I am honestly a side effect of that, our system, in that I trained at a big tertiary centers, right? Pediatrics residencies are always linked to a big centers, because by nature. So I did not even like dream or think that there could be this model where I just felt like that was like horse and buggy, long time ago model that's no longer accessible. And then looking into it, one of the ACGME requirements is the, practice-based, like we have those core competencies we have such good basis to educate our young learners in, medical knowledge, what it means to be a doctor, how to be an advocate, how to understand the healthcare system as a whole, where you can help people save money, and to really do all of that. And I think if we could incorporate those types of programs where we have a resolution from our independent section written to help with that. It's not about that one model is better than another, but all of these models together is what we need. Because it truly transforms healthcare. Like I talked about from the business side of things for direct primary care. From an insurance side of things, what does insurance always talk about? Fraud, waste, and abuse. Why they ask to, pre-approve and prior auth and all of that to prevent fraud, waste, and abuse. Direct primary care forces the question on our patients that says, do I need this? And how much does it cost? Those two questions alone takes away fraud, waste, and abuse. That whole department doesn't need to exist. Healthcare dollars saved. So it transforms from a business model, from an insurance model. It transforms, it for physicians, it's a total win-win because you get to do what you went to medical school to do, which is to take care of patients. Spend not, right now, I think 50% of a physician's time or more is spent on administrative tasks and negotiating and all of that. And your time is actually spent with patients. And then from a patient, they get better, they have care, they have access. It almost sounds like utopia, but it really is, you know? Um, as you can see, I'm very passionate about it because
I can
it's a
see
win.
that.
It's a
That's wonderful.
win-win. It decreases cost, increases quality of medicine. And those two things are usually do not go together. Decreasing cost and increasing quality. And DPC does both.
Fantastic. Is there anything else you would like to make sure that the people who watch this know?
Um, I think it just, take that plunge, look into it. There's DPC conferences, there's other DPC doctors, there's something called a DPC mapper. It's if you Google DPC mapper, you can put your own zip code and see how many direct primary care clinics are around your community. And just go for it if that's something you think. I don't know if you know this, but there's also direct specialty care, where that is really starting to boom too. So I think there is a market for direct. It doesn't mean everything else isn't, I think our system has a lot of good people, from hospitals to insurance to, it doesn't matter what the field part of it is. I think the individuals in our system is wonderful, but the system as a whole is not set up to thrive for what's best for the patients.
Fantastic. Well, I thank you so much for telling us about this model of practice, and I hope a lot of our younger physicians will be inspired to join you, to join
Thank
you in
you
what you're
so
doing.
much, Dr. Lucas Fain.
All
It
right.
was wonderful to chat with you about this.
All right.